So thank you for joining us today. It's time that we start now. Um, Today we'll talk about the latest insights from the Better Registry concerning type 1 diabetes. Thank you for joining again. If you have colleagues that weren't able to make it or you can't stay until the end, there's no worries. This is recorded and we will be sending you the link to the replay after the session. So before we start, I'd like to introduce our speaker today, which is Anne-Sophie Brazeau. She is the co-founder and director of the Better Project. She is the associate professor and director of the dietetics program at the School of Human Nutrition of McGill University here in Montreal. She's a registered dietitian and member of the Ordre des diététistes nutritionnistes du Québec. Her research program focuses on type 1 diabetes and how to support individuals in their self-management of the condition. She has particular interest in nutrition and how it aligns with emerging diabetes technology. Before I hand it over to Anne-Sophie, I just want to remind our guests that if you have any questions, feel free to use the Q&A function at the bottom of your screen, and we'll be answering them at the end. So I'll let Anne-Sophie present her talk, and I'll come back for the questions at the end. Thank you.
Thank you, Emily. It's a pleasure to be here today and to present to you some findings from the Better Registry. Um, so as Emily was saying, it's going to be recorded. So if you miss some part, you'll be able to catch up later. So we'll talk about the Better Project in general, just to remind ourselves of what is the Better, but then we'll focus more on the registry part of the Better Project and what we have learned and published on some findings from the Better Registry. So the Better Project started 8 years, 7 years ago, 8 years, we were sitting at a table and trying the first ideas of what could be the Better Project. 8 years ago, we got the funding and really developed this project, which is to better understand type 1 diabetes in Canada. And so there's three big pillar of the Better Project. We have the Better Registry, which is what we'll be talking today about. We have a series of self-training platforms for diabetes self-management, which are the support platform. And we have also some clinical research and a biobank also to further do research in this area. So our mission is really to help with type 1 diabetes management and improving the life of those living with this condition by accelerating research, knowledge, having more easiest way of getting people involved into research, promoting access to training and information, as we believe this is key for helping people really take ownership on managing their condition, and also using the information we are getting from the research we do to raise public awareness and advocate for better access for treatment and technologies for this population. And so when we developed this project, it was and it is still in collaboration with patient partners. And so a first or our initial interest was really to help reduce the burden of hypoglycemia, because that was what the patient partners were asking us to do when we first sat down with them. But they have also helped shape how this project has evolved from being more hypoglycemia centered to a more broad approach of what is living with type 1 diabetes. And so the Better Project is a collaboration with health professionals, researchers. We have several students that are being trained in research and healthcare providers being trained with this project. We also talk with some decision makers, and the idea is really to have something that is answering the needs of patients and that can help us all in our practice. I co-founded this project with Dr. Remy Rabazalore, and we've been working with this amazing group of patient partners since then. And so Today we'll talk about the Better Registry, one of the pillar of the project. And I'll take some time to just explain what is the Better Registry so you kind of get the methods for all the results that I'll show you after. And so the Better Registry involve people with type 1 diabetes or LADA in Canada. It was developed with the patient partners and its prospective cohort. So we have repeated measurements over time. People do a baseline questionnaire, are then reinvited to do more in the upcoming years. It includes people of all ages. So we have children in the Better Registry, which are their parents answering some questions, but we also have adolescents and adults, so all ages included. And it's a real focus on patient-reported outcome, so PRO, and PRE, so patient-reported experiences. So we have a series of questionnaires. Some are standardized questionnaires that can help with harmonization with other studies. So we want to be able, I'll present to you data from our Canadian cohort today, but in the future, we will be able to also compare our population with some other population living with type 1 diabetes in the States or in France, for example. So it's mainly questionnaires, but we also have some direct measurements like data from CGM, for examples, um, or blood lipids. So people self-enroll in the Better Registry, but what we do is we try to recruit them through several means. So sometimes it could be someone going into clinic and presenting the registry to people living with type 1 diabetes. Sometimes we go to some event for people with type 1 diabetes and we present them this project. Sometimes it's through social media. We have a large presence on social media, so we try to keep getting people enrolling in the registry. And so how it works is once they have heard and decide to contribute to the registry, they are asked to fill a first initial questionnaire. And then we ask them if they want to do a second one and a third one. So it can take up to 90 minutes at baseline to go into the registry. This is also explain why we don't necessarily have a large amount of people doing all the three questionnaires. We have, but the 5,000 people have all done the baseline, the initial questionnaire of baseline at baseline. And then we invite them for annual follow-up, which is a shorter duration type of questionnaire. And now we have people that have done almost 6 years of follow-up. So we're getting interesting data as well. So in the first questionnaire, we get general information about their diagnosis, if there's any complication, what kind of treatment they're having. We're asking them who they are, so a bit about their socioeconomic status. And we do ask them a question about serious and severe hypoglycemia, which are level 2, level 3 hypoglycemia, since it was a big ask of our patient partners at the beginning, so we better understand hypoglycemia. If they want to move on to the second questionnaire, we get a bit more about their story about diabetes management. We have some standardized questionnaires about fear of hypoglycemia, hypo and awareness. We ask a bit more about their medical history, medication, and so on. And if they want to move forward with the third one, then we go into sleep habits, mood management, stigma, social support, barriers to physical activity. We go a bit more in depth about what are the consequences of living with type 1 diabetes. We have a series of measurements, so we can participant can upload their CGM data, blood test results, medication list. We can send them a podometer, so we get also some information, objective data on physical activity. They can measure their waist, and we ask them also to do 24-hour food recall. So we have a bit of question information about dairy intake. And so today I'll present you some results on this population. So since this winter, we have reached more than 5,000 participants in the registry. So on average, the average person would be a white woman, 40 to 45 years old. But you can see that we have some kind of a distribution here. So we have a bit less than 20% that are children 13 years and under, but we have then adolescents and adults up to more than 65 years old and more. Mainly women, two-third women, one-third men, but we do ask about the gender they identified with. So we do have also some people that don't necessarily identify as neither a man or a woman. In terms of ethnicity, as I was mentioning, we have more people that are Caucasian. However, we do have some other ethnicity represented, and we are trying to expand on this diversity of people in the registry. The Better Registry started in Quebec first, so we still have about half of all the participants that are coming from Quebec. However, this number is declining as we are getting more and more people from the other provinces and territories in Canada. When we first published on the results, so the numbers that are crossed, those were the numbers back in 2022 when we had this first publication of who are in the Better Registry and what is the Better Registry. So at the beginning, we were more around 80% of the participants that were using CGM, so 2019, 2020. What we see in the most recent data is that this proportion has increased to more than 90% of the participants in the Better Registry being users of CGM. And we have seen also an increase of the proportion of participants in the Better Registry using an insulin pump. So from 41% in our first analysis, we are up to 45% now. The one great thing is that we've seen the proportion of people not achieving a A1C less than 7 declining. So that means that more and more people report having an A1C at the 7% target. However, it also means that more than like the majority still are not at target, despite this quite good use of technology. And despite this use of technology, what we also see is that hypoglycemia level 2 remain quite frequent, with 75% of the participants reporting at least one episode in the last month. And there have been no changes in the proportion of participants reporting a severe hypoglycemia, level 3 hypoglycemia in the last year. So it's at 13%. So, so those are our people. So what have we learned on them? And so one of our first analysis was to look at the impact of socioeconomic status on diabetes complication. And so we were looking at some indicators of the SES status. So if someone doesn't have a private insurance, their greater proportion were more likely to present at least one complication of diabetes. The job status, so if you're unemployed, also reporting a greater proportion having complication of diabetes. Level of education plays a role as well here, and income in the income per year. So those, as you can see that as the income decrease, the proportion of people presenting complication increase. And so among those four indicators of the SES status, the income was the one that was the most significantly associated with higher A1C, more microvascular complication, more depression, more severe hypoglycemia. So if there's one that we want to pay more attention to is definitely the familial income. And we have more that will come on access to technology according to the socioeconomic status. Dr. Wiseman in Toronto did analysis of the data, and we can also see some inequities in access, or in not necessarily access, but in the use of technology, depending on the socioeconomic status. As I mentioned at the beginning, we made an effort to better understand the hypoglycemia that people are facing with type 1 diabetes, how it may remain frequent despite technologies. And one of the things that we wanted to explore a bit more is the consequences of those hypoglycemia. And so one of the analyses we did was to look at the frequency of the hypo level 2 and 3, and to compare men and female, men and women. So we have about one third, two third that were men and women, and what we see is that women are presenting more hypo 2 level 2, more hypo level 2 in the last month. So there was a greater proportion. Almost 85% of women reported at least one. And when they report an hypoglycemia level 2 in the last month, or a serious one, less than 3 millimoles, they present with more. So compared to men, it was 3 versus 4 episodes in the last month. We didn't see any difference on severe hypoglycemia. The proportion of participants having one in the last year was similar, but women present a greater proportion of women presented low self-confidence to handle hypoglycemia, as well as there was a greater proportion also experienced higher fear of hypoglycemia. And so again, showing that men and women, it's not only about the number of hypoglycemia they have, but they also don't necessarily have the same apprehension of those hypoglycemia. And so we look at the consequences on different levels. One was on the diabetes management itself. So it's about two-thirds that reported that having a level 2 hypoglycemia was associated with consequences, either that they monitor their blood sugar more frequently after they adjust at least one insulin. About a quarter said that they started consuming more carbs after a level 2 hypoglycemia. So consequences on the diabetes management was quite frequent for level 2 hypoglycemia, even more with level 3, where monitoring the blood glucose was the key one that we've seen an important difference. But you can see that as many people were said that they adjusted their insulin after those hypoglycemia. Women more than men reported several consequences on the impact that it may have on health services. There was no difference between men and women. Level 2 hypoglycemia didn't have as many consequences on the health services, which we see with the level 3. So, but you can see that only 14% reported discussing those hypoglycemia and medical appointment. And so there might be room here to have more discussion about those level 2 hypoglycemia with our patient, especially when we were talking about women that may fear or have more anxiety related to hypoglycemia. And this is also what we are presenting here. So when we ask about the impact it may have on daily life and on the physical and mental health, hypo level 3 has most people report consequences, two-thirds of them, especially anxiety, persistent fatigue, shame. That was even more among women. So when you see the little women draw in the figure, that means that this proportion was even higher among women. But this fatigue and this anxiety is also felt by people with level 2 hypoglycemia. And so I think there's room to also discuss how those level 2 hypoglycemia, although we don't report on them as frequently, do impact on the life of people with type 1 diabetes, and especially the women. And so Despite the use of technology, level 2 and 3 remains quite common. They have consequences on daily management of diabetes, and especially for women, consequences on their physical and mental health. So we may want to pay attention on the consequences a level 2 hypoglycemia may have, even though we're not necessarily asking for those hypoglycemia during medical appointment. We also discuss with the participant an easier or a different definition of severe hypoglycemia. We wanted to see if the definition that were proposed by patient, a low blood sugar that you can treat by yourself, is as good as the medical definition of hypoglycemia, where we say we need help from someone else, maybe use glucagon, hospitalization may result in loss of consciousness. And what we saw is that the patient definition was working as well as was very similar with the other one. There was not a lot of differences between the two, and this is according to the level where you feel your hypoglycemia. We can see that there's more severe hypoglycemia if you have more hypo unawareness, and both definition perform similarly. So there are potentially ways of easing the way we ask about severe hypoglycemia that it's the hypo that you cannot treat alone. It may lead to less false negative where someone got help from someone else despite not necessarily needing that help. So we believe that this is an interesting way of asking for severe hypoglycemia. We also look there's a typo in the title. Prevention of nocturnal, not hypotension, but hypoglycemia. Depending on the technology used, we were asking participants what they were doing to prevent those nocturnal hypoglycemia. So that was analyzed. We did in the first a bit less than the first 1,000 of participants in the better registry. And what we see is that the most frequent strategy being used is to monitor blood glucose before bedtime. And this remain depending on the type of technology that you're using. If you're having an insulin pump, if you're using a CGM, every 3/4 of them says that like they were paying attention their blood glucose before going to bed. The second one that is the most used is to have a snack before bed, and that we saw that it really changed if you're using technology or not. And adjusting basal insulin is not something that the participants are doing as often as the other strategies. But again, this varies a lot if you're having an insulin pump or not. So people on an insulin pump, there was up to 42% that said that they were adjusting their basal insulin, and that declined according to the other group. Other strategies like reducing alcohol intake or reducing a physical activity before bedtime is not something that people do in a mindful way to really prevent an hypoglycemia. Um, so it does depend a bit according to the technology we have. And what we see is that pump users snacks significantly less and reduce their basal insulin more. So there's a lot of flexibility that can be provided with the use of technology, but it still remains a concern. They still do a lot of action to prevent those hypoglycemia despite the use of technology. But again, this was done in 2022, so it's not that recent, and we can expect that those strategies to prevent hypoglycemia may change with the new integrated automated insulin delivery system that we have now. We also look at the prevention of hypoglycemia in the context of physical activity. We have a lot of interest because we know that there are several barriers to physical activity and that fear of hypo is a key one for people with type 1 diabetes. So we were interested in looking at what strategies people use because we know that there's different ways we can try to adjust to minimize those hypoglycemia, and we were interested to see if women and men were doing differently. And so the key one, again, monitoring blood glucose, is what people were saying was the top strategy used. And then it was to to eat carbs before they exercise. And when we look at those numbers, what we see is that more men report using eating carbs before exercise to prevent hypoglycemia, although it's still the second most used strategy. Eating carbs during exercise is also quite prevalent among men, decline a bit more among women, and reducing insulin at the previous meal is also a strategy being used, but in a smaller proportion of people, and there's no difference between men and women. And so women report eating carbs less than men, but they also report doing it less frequently than men. And this is what we see on the figure on the left of the screen. What you see is that there's more men actually saying that they will eat carbs to prevent hypoglycemia during physical activity frequently or always, while women will say that they do it, but they do it sometimes. In terms of adjusting insulin, there's no difference between men and women. And so what we saw in this analysis of the data is that more women were having more presented more barriers to physical activity. We had a questionnaire for that. But they considering the fact that they are less inclined to consume the carbs during physical activity, maybe we need to find other source of support to help or other strategies to help to prevent those hypoglycemia. There's definitely room about how to adjust insulin during exercise. We were asking questions about use of sprint or basal pump insulin adjustment. And what we saw is that those strategies are very minimally used and there's no difference across gender. So we'll move a bit away from all the hypoglycemia, which we still see that it's still a big burden and that women seems to be more impacted and don't necessarily take the same strategies or action to prevent them than men. So we'll just keep this in mind that we need to have to individualize our approach when we give recommendation. What we've seen also in the Better Registry, and that's a paper that we published quite recently, is that more than half of the participants are classified as having a BMI over 25. So it's about 55% being overweight or obese according to the definition by BMI. More frequent if you are a man, if with longer duration of diabetes. Overweight and obesity is associated with higher insulin dose, more insulin resistance. And what we saw is that there's a greater proportion of people overweight or obese also taking additional medication for hypertension and cardiorenal protection and for depression. There was no difference in the technology used for diabetes management. There was no difference in self-reported A1C. And if you were classified as BMI over 30, we saw even more complication, microvascular complication, neuropathy, retinopathy were more present. And there was also a greater use of adjuvant treatment for diabetes. And so we did a little look at the data. We have about 14% of the adult population in the Better Registry that report taking another medication for diabetes. So the key one was metformin. About 30% will say that it's metformin, but more and more we're seeing also participants taking some SGLT2 inhibitors or GLP-1 receptor agonists. And those reporting taking those extra medication are the one with a BMI higher, a bit of older people, and those who present cardiovascular complication, and a greater proportion also taking additional medication for cardiorenal protection, dyslipidemia, depression. So this is something that we've seen this number increasing in years, and it's become more common among people with type 1 diabetes. As mentioned a bit earlier, we have 24-hour recalls on a subgroup of participants. So we were interested in seeing how people are eating. And so what we saw is that unsurprisingly, people tend to be on the lower side for carbohydrate intake. So it's a bit less than 45% on average, the proportion of energy coming from carbs. And what we wanted to see was actually the proportion of people that were considered following a low carb diet. So we were looking at people that were taking 30%, about 30% of energy from carbs. So that's about a quarter of all the people that provided us with 24-hour recalls. And what we see is that if they cut on carbs, it was really the energy from fat that increased, not that much from proteins. And across the groups, it was similar amount of fibers. It was a similar number of servings of vegetables. There was the intakes of fats, as I mentioned, was higher, but it was all the different subtype of fat that was increased, not one in particular, and a bit higher proportion of meat alternative being consumed. So we look at if there was differences according to what they were eating. We didn't see any difference in body weight. We didn't see any difference in blood lipids. So we do have blood panels for a large group of the people that have provided us with 24-hour recalls. There was no differences in the presence of cardiovascular disease. Insulin dose were slightly less in this group that have cut a bit on carbs. And there was a greater proportion achieving a A1C less than 7 without any difference on hypoglycemia, number of hypoglycemia or severe hypoglycemia. And so what we saw here is that cutting slightly on carbs was associated with an increased amount of fat, but with similar diet quality, there was similar cardiovascular outcomes. And so we can support most likely people that decide to cut a bit on carbs as they see some benefits for their diabetes management. We are quite interested in the use of technology. So we did an analysis of those that were using some early adopters, I would say, of automated insulin delivery system. And so this is an analysis that we did on 130 participants that were either using Medtronic 670G, SET70G, or the Tandem Control IQ, which were the one that were available at the time when we did this analysis. And so we were interested in understanding who are the ones that meet the A1C target less than 7%. And so we look at all those people, compare the two groups, and there was only two elements that really stand out after adjusting for everything. People who have been using an insulin pump for the longest were less likely to report an A1C less than 7% on automated insulin delivery system. And people holding a bachelor degree, so the education level was positively associated with reaching a A1C less than 7. But those were the only two characteristics that were different between those who achieve A1C less than 7 or not. And so what it tells us is that everyone or anyone can reach this target. There's not much differences on the socioeconomic status or the clinical characteristic. Everyone can benefit from technology to achieve those A1C, but we may need to provide more training or more support with those who have a lower educational level, or if they have been using an insulin pump, they may need to adapt to those new technologies to really benefit from them. We were quite surprised. We were not expecting that those on using a pump for longer would be associated with less people reaching this target. As I mentioned a bit earlier, we have a participants from all ages in the Better Registry. So we've been looking at those that are a bit more senior and see what is their use of technology. Is it different from those in their 50s, 60s, or 70s plus? And what we saw is that there is no difference in the proportion of people having insulin pumps. This proportion is a bit lower than the in the overall cohort. But CGM use was also CGM are very used, except in the group above the age of 70. So we don't know if they have, we haven't looked in details if they have used it before and it was discontinued, but most likely they haven't adhered to this technology. We don't know if it's because they have not been proposed to use this technology because they may have less private insurance. The coverage was not necessarily available at that time. We don't know, but we can say that though in this group, the people in the 70 and plus group were using a bit less of the CGM. But their use of those technology was similar between the groups. There was not that much differences in hypoglycemia. Actually, there was a bit less hypoglycemia in the group in the 60 and 70 ages. There was a bit more in the youngest. And we saw that the diabetes-related distress was declining with age. So there's less distress as we age with diabetes. So we believe that we are presenting people that are aging quite well with diabetes in this cohort, so it may not be representative of everyone. 80 to 86% were reporting an A1C less than 8%. So we know that we are sometimes more liberal with the diabetes, the A1C target in this population. So that we have a good proportion of people that are aging well with diabetes here. We saw that those that were using technology were the one on having still private insurance or the people that were not from the province of Quebec. So there's like two hypotheses here for the people outside Quebec. Could be linked to the reimbursement of technology, but could also be linked to who are the people that are enrolling in Better more recently. So are they people that are interested in the technologies and they want to tell us about their experience using this technology, which might be a bit different from the initial people that enroll at the beginning. A bit of take home, a large proportion of adults in the better cohort use technologies and insurance status is associated with whether or not technology is used. So I think we still need to advocate for access to technologies in all those groups, and there's room for having even more using technology if this is what they want and if they have the capacity to use it. Finally, another area that we were quite interested in studying was diabetes-related stigma. And so participants in the Better Registry that decide to go up to the third questionnaire will answer a questionnaire on stigma, the DSAS-1 scale. And so people are to answer if they strongly disagree or strongly agree with this statement and it give us a score. And so there's three categories that are explored here. Being treated differently, we have 6 items on that. The blame and judgment associated with diabetes, 6 items, and some identity concerns. And we were interested in better understanding how people perceive stigma. And what we saw was that women in blue compared to men usually present or express more diabetes-related stigma than men. And younger age was also the one that feels stigma the most. It was not necessarily for being treated differently. It was mainly the blame and judgment that were the item that were really endorsed by the participant, and some identity concern among the youngest participant. And again, like we can see that the 14 to 24 in those two categories were really the one that felt the most the stigma. And so when we talk about blame and judgment, what it looks like more than half of them feel judged when they eat something sugary foods or drinks. Uh, about a third receive unfair assumption about what they can or cannot do because of their type 1 diabetes. A lot of people still report having other think it's their fault if they have this diabetes, and it's their fault if they have to take insulin. And so it showed that we still need to educate society about what is type 1 diabetes because there's still a big misunderstanding. And feeling more stigmatized is associated with more diabetes distress, more behaviors to avoid hyperglycemia. And so those behaviors can be also negatively impacting their diabetes management and can put them at risk. They feel more hypoglycemia. We had a higher proportion also showing signs of depression if they feel stigmatized. So we need to support them, and those who perceive the most the stigma were the one that felt that they were receiving sufficient social support. So we have a scale, a questionnaire on social support as well, and those stigmatized that feel stigmatized the most feel also the less supported. And so I think we can still do a bit more on stigma to help them and reduce the stigma related to diabetes. But I will move on because we don't have a lot of time left. And I just want you, it's out of the press. It's really recently published. We have a question about who's wearing a medical bracelet, medical ID. And what we can see is that most people with type 1 diabetes report not wearing a medical ID, especially men. So more women were wearing one. The one that wear medical ID feel less the perception of stigma. They feel less diabetes related distress. So they would, I would say, more positively live with their diabetes. Those who don't wear a medical ID were the one that fear being judged by others about the fact that they have diabetes. And surprisingly, those who don't wear a medical ID were the one that were not wearing any signs of diabetes, like an insulin pump or a CGM. So this group may be very less comfortable having their diabetes in society, and we need to make sure that there's other ways for them to let other people know, especially when there's any emergency situation that they have diabetes. So this was a snapshot of some of the published data on the Better Registry, but we will have more coming up soon. We have been looking at data on sleep, on multiple autoimmune diseases that some people may have, on insulin ambition for weight management, on physical activity and barrier to physical activity. And we are starting also to look at the prospective data. So what happens when you start a new technology? We've seen changes in the recent years, and so more data will come from the Better Registry, and we believe and we hope that it will help you with your practice as well. So if you want to read more about our publication, you can find all of those on our website, the Better website. If you need any material for recruitment and you want to help us increase awareness about the Better Registry, we have material that we can send you. Feel free to contact us, and I'm pretty sure Emily can put in the chat where to reach out to us. And there's a lot of people behind the Better Project, and so I just want to thank them all for their help and support in better understanding what it is to live with type 1 diabetes in Canada nowadays. Amelie, I'm very sorry I've been talking for too long and I didn't leave a lot of room for questions.
Thank you for your talk. It's because we have so much wonderful data to share, so I think it might have been of interest for our audience. I think this is really rich since it comes from the people living with the condition themselves. So thank you for this. If any of you have questions, we can take a couple minutes if you want. Feel free to write them in the Q&A.
But if you have question after, you can also write to us at Better, or you can write me, and I'll be happy to answer any question you may have after watching this webinar.
So on our website, Type 1 Better, so our colleague has put the link in the chat box. So if you want to download and print materials directly to advertise for recruitment in the Better Registry, the link is in the chat. We thank you very much for your attention. We hope this was relevant to you in your practice, and we will be sending out the link for the replay sometime soon. Thank you, Anne-Sophie. Have a great afternoon, everyone.